Hi, everyone. All right, we're going to jump right into clinical monitoring and start out with our AANA monitoring standards. So this is standard number 9, so make sure you review this on the website and read exactly all of standard 9. And the monitoring standards cover oxygenation, ventilation, cardiovascular, thermoregulation, and neuromuscular systems. And oxygenation, we want to make sure, well, oxygenation and ventilation, they kind of fall under the same category, but it's continuous observation of ventilation and oxygenation. And we either do it by clinical observation, pulse oximetry, and if we need ABGs, we do that as needed as well. Ventilation, we may auscultate, use chest excursion and end tidal CO2 to verify placement of an ET tube or an LMA. We use any pressure monitors as needed, and we monitor our respiratory rate a maximum of every 5 minutes. Cardiovascular system, an EKG, auscultate as needed, and we monitor our blood pressure, heart rate a maximum of every 5 minutes as well. Now, you will see some providers that document every 3 minutes. I'm an every 3 minute person that documents. It's just ingrained, and that's just how I was taught, and so that's just how I do it. There's nothing wrong with every 3 or every 5, but you do not want to go beyond 5 minutes. You always want to make sure that you're documenting at the very maximum of just 5 minutes. And thermal regulation, whenever it's when clinically significant changes in body temperature are going to be anticipated. So is it going to be a very long case, or if it's a child, or this patient has issues with hypothermia, you want to make sure, or a history of MH, you want to make sure that you are monitoring it appropriate by the appropriate means and documenting as well. And neuromuscular blockers, we only document those when we give them, and we monitor them only when we give them. We don't give every case that's not indicated for a paralytic, so we don't necessarily need to monitor every patient if they have no paralytic on board. But we will always continuously monitor ventilation and our oxygenation status and cardiovascular status. Those will always be continuous. Like I said, thermoregulation, if it's a very short case, and it's not a continuous monitoring of temperature per se if it's a short case, because we have some cases like colonoscopies, EGDs. We don't necessarily monitor that continuously for the 5 or 10 or 20 minutes that procedure may last. You get a temperature at the beginning of the procedure, and then you get one at the end or when they go to pack you, but it doesn't need to be continuous. So if there's any additional means of monitoring, we do that as it is based on the needs of the patient, surgical technique, or procedure. So if there's like a particular type of, so for instance, if a surgeon wants you to do a hypotensive technique, you document exactly why you're doing that hypotensive technique, and you document very well just in case something happens, like a stroke or something as a result of it, because that is a clear that's a problem, and it's usually due to the hypotensive technique if the blood pressure got too low. So you have to document exactly why you're doing it. And if you are omitting something, you need to make sure that reason is charted. And this is just the link to the practice document as well. All right, so moving on to pulse ox. So this is, as a quick review, our standard dissociation curve. And so we know that the SaO2 is a function of the PaO2. And the saturation of hemoglobin in arterial blood is related to the arterial partial pressure of oxygen. And SaO2 and hemoglobin are major determinants of the O2 content in blood, and consequently the O2 delivery in the tissues. So when we have a right shift, we know that it's releasing or unloading oxygen, or hemoglobin, and we have a decreased affinity. And those conditions that it happens in are acidosis, hypercarbia, hyperthermia, or an increased 2,3-DPG. Left lock, or left shift, we have the hemoglobin holds on to the oxygen more, so it has a difficult time releasing it, so we have an increased affinity for the oxygen. So in conditions of alkalosis, hypocarbia, hypothermia, I should say decreased 2,3-DPG, carboxyhemoglobin, or carbon monoxide poisoning, for instance, or fetal hemoglobin. Those all would cause a left shift. Now, for this chart right here, so right here, this is saying that at a PO2 of 60, the predicted or given O2 sat would be approximately 90%. Okay, so we know that if our PO2 is 40, we can predict our oxygen saturation to be 75%. And if a PO2 is 27 millimeters of mercury, we can predict the O2 sat is about 50%. And this is for adults in normal conditions or a healthy adult where there's no other comorbidities or no other problems going on. These are the predictions that can be made on this PaO2 here. And so also remember, when we are reaching this flat portion of the curve up here, that our PO2 can actually fall from 100 to about 60, and still our O2 sat will remain 90%. So this is kind of, you can think of this as a safe zone where we can, where hemoglobin can still load a fair amount of oxygen at the lungs, even if there's like a problem with diffusion or some problem with oxygenation. We still got there's a mighty big window that we have with the PaO2 before we see oxygen saturations begin to fall. All right, so jumping into how our pulse ox works. So pulse ox basically is this light being transmitted through matter, or light through matter, and it can be transmitted, absorbed, or reflected. And the Beer-Lambert's law essentially is a law of absorption, and it basically states it's relating the transmission of light through a solution to the concentration of the solutes in that particular solution. So a more concentrated solution would absorb more light than a dilute solution does. And what this is also referring to is that light absorption must be measured at wavelengths that are proportional to the number of solutes that are in that solution. So the absorbance of the light is proportional to the, it's essentially, so when light is traveling through a concentrated solution, that light, the more concentrated the solution is, the more light that's going to be absorbed by the solutes in that solution. Now, if this solution is less concentrated, less light is actually going to be absorbed in that solution. So I have an example on the next slide to kind of explain that a little bit better. So here in this first slide, we see this is a finger and a pulse ox probe, and this represents an artery. This is a vein. And these things that look like tomatoes or apples, they're actually hemoglobin. So if we have a low concentration of hemoglobin here, and then these are our light waves going through, we have less absorption of the light waves by the hemoglobin because we have a low concentration. So that means more light is going to get through to the other side of the pulse ox. Now, if we have a high concentration of hemoglobin in the artery, and we have the same number of wavelengths of light going through, most of that light is going to be absorbed by the hemoglobin, and so that means less light is going to get through to the other side. Now, it also, with Beer-Lambert's law, it's also talking about the length of the light path. And so this is the artery again, and assume, I know the concentrations are different, but let's pretend that the concentrations are exactly the same. The hemoglobin concentration are exactly the same here. And so this is a normal artery, and this is an artery that's dilated, so it has a longer path. So same concentration, it's just a smaller artery. The artery has a smaller size, so there's less path length for these wavelengths of light to travel through. And so, since it's a shorter length of light, or it's a shorter path length for the light to travel through, um, there's less light being absorbed, and more light reaches the other side of the pulse oximeter probe. Now, with a dilated artery with the same amount of concentration of hemoglobin, there's more as a longer length for the light to travel. So actually more light is going to be absorbed in the artery because it's wider, it's got a longer path for it to travel through, and so less light is going to make it on the other side of the pulse oximeter probe. Moving forward to talk about the different types of hemoglobin. So there's 4 types of hemoglobin that are that adult blood can consist of, and that's oxyhemoglobin, reduced hemoglobin or deoxyhemoglobin, methemoglobin, and carboxyhemoglobin. Now, under normal circumstances, the concentrations of carboxyhemoglobin, and methemoglobin are small. They're less than 3. It's about 1 to 3% for carboxyhemoglobin and less than 1% for methemoglobin. And you see that at different at red light or red light here, and then at infrared light, you can see that that these different types of hemoglobin are absorbed. So this brown one is methemoglobin, and methemoglobin and the deoxyhemoglobin or reduced hemoglobin, they're actually absorbed at about approximately the same wavelength for red light. And over here on this side, you see that methemoglobin absorbs more infrared light than just about all the other hemoglobins. So it absorbs more infrared light than oxyhemoglobin, reduced hemoglobin, and you see that carboxyhemoglobin is basically invisible. It at 940 nanometers, it doesn't absorb any light. Now, we also see that oxyhemoglobin and carboxyhemoglobin, they pretty much absorb red light at the same amount, just about as well. And we'll talk about the significance of that later. But 660 is red light and 940 is infrared light. So in co-oximetry, it uses the principle of oximetry to measure the SaO2 as well as concentrations of other hemoglobins in a blood sample. So this can be done in a lab in vitro, or it can be done in vivo, so like with a probe. And so with the probe, the co-oximeter probe, those are available. They measure all 4 wavelengths: oxyhemoglobin, reduced hemoglobin, methemoglobin, and carboxyhemoglobin. And this is the gold standard if the pulse ox is inaccurate, or if a pulse ox cannot be used. This co-oximetry is the gold standard. So if you have a patient that has like carboxyhemoglobin circulating because of carbon monoxide poisoning, and you're waiting on lab results, if your facility has a co-oximeter probe, that could actually help pick up that and detect that as well. So next, like I said, red wavelengths of light are at 660 nanometers, and infrared wavelengths of light are at 940 nanometers. Deoxyhemoglobin absorbs more red light than oxyhemoglobin, and we see the deoxyhemoglobin absorbing in right here because it's higher than the oxyhemoglobin. This blue line, we see it absorbing more red light, and then it absorbs less infrared light than oxyhemoglobin. So oxyhemoglobin absorbs more infrared light than deoxyhemoglobin. Okay. So when we're looking at how a pulse ox actually measures our O2 saturation, it depends on the pulsatility of the arterial blood flow, and that is really what estimates the SaO2. And so when we're looking at the pulsatility of arterial blood flow, we're looking at AC, which is alternating current, which is the pulsatile portion, and we're looking at DC, direct current, which is the non-pulsatile portion of arterial blood, venous and capillary blood, and tissue as well, and skin as well. So we're looking at all of these different things that light absorption has to go through in addition to the pulsatility of arterial blood flow for the pulse ox to read. And so it's a ratio of the AC and DC light absorption. So the pulsatile expansion of the artery increases the length of the light path, which increases absorbency. And we look at the pulsatile component divided by the non-pulsatile component for each wavelength. So we would look at, for 660, we would look at the pulsatile arterial blood divided by the non-pulsatile arterial blood, the venous capillary blood, and the absorption from the tissue, and then take that divided by the pulsatile component and the non-pulsatile component at the 940 wavelength, and that gives us our ratio, which allows us to estimate our SaO2 via the pulse oximeter probe. So carboxyhemoglobin, because we've talked a bit about that. So like I said earlier, it absorbs as much light in the 660 range as oxyhemoglobin does, and because it does absorb as much light in the 660 range, and then it virtually absorbs it virtually absorbs no light at the 940 range. In patients with carbon monoxide poisoning, the SpO2 will be actually falsely elevated. And so when we see someone that possibly has carbon monoxide poisoning, it won't reflect that in a normal with our normal pulse ox probe. That's why co-oximetry would probably be the best bet for that, or doing co-oximetry in vitro in the lab, because the pulse ox will not recognize or will not see it at 940. So it has nothing to, it can't compare that ratio as it was doing with the, we can't see that because it's virtually, there's no light there at 940. And so we also know that carboxyhemoglobin increases hemoglobin's affinity for oxygen, and so that prevents the release of oxygen to the sites two sites, and that results in a left shift, like we talked about earlier. And these patients usually they look pink, or their skin, they don't look dusky or blue. Their skin is bright pink, or if they're brown, their skin looks normal, or they have cherry red lips. Their skin, everything appears to be normal, which also by inspection is abnormal, because even with carbon monoxide poisoning, the tissues are holding onto the oxygen, the hemoglobin is holding onto the oxygen, so everything appears to be fine. But it's not fine because the tissues aren't getting that oxygen. And so this is misidentified as good oxygenation when in fact the tissues are severely compromised because they're not getting the oxygen release that they should be normally getting. And so the PaO2 will appear to be normal because our hemoglobin is holding on to that oxygen. So in the setting of elevated carboxyhemoglobin levels, our pulse oximeter will overestimate oxygen saturation by 1% for every 1% increase in carboxyhemoglobin. And many smokers will have greater than 6% carboxyhemoglobin just due to the carbon monoxide that is produced when they are smoking. We get signal artifact in pulse ox because ambient light, so sometimes, and so if ambient light is getting into the pulse oximeter probe, we get some signal artifact, but it's usually solved by alternating the infrared and red lights. And so when you see that flickering, sometimes that It's really fast flickering that you can see, or alternating of the lights if you really take a second and look at the pulse ox probe. Low perfusion, our signal amplitude is reduced. So when we have low perfusion or low cardiac output, we are prone to see some signal artifact. If we have detection of venous blood pulsations, that is a reduction. It results in a reduction in the presumed arterial SpO2 as well. Additional light absorbers, so any intravenous dyes, and sometimes we give methylene blue in the OR, and that could absorb some light, and that could give us some signal artifact as well. New pulse oximeters, however, can monitor up to 12 different wavelengths versus our 2 wavelengths, which is what the standard traditional pulse ox probe monitors. So that could actually alleviate that signal artifact there. And any additional forms of hemoglobin that are available, we get some signal artifact, just like if there's methemoglobin in the blood or carboxyhemoglobin. And nail polish, we know that dark nail polish, dark blues, blacks, that can produce some signal artifact as well. Advantages. So it's fairly accurate, within plus or minus 2% when measured against an ABG if the stat is greater than 70%. And it's not affected by anesthetic vapors at all, so that doesn't change the reading. It's not invasive, it's continuous. It may indicate a decreased cardiac output as well. It's convenient. We have tone modulation, which is great. So if you are doing something with the patient, or maybe checking an arterial line or checking a Foley or something, if you're checking urine output, if you hear the tone starting going down, that your patient is desaturating or something of that nature is happening, so you can react quickly. There's different varieties of probes, from finger probes that can be attached to the forehead, probes that can be attached to the nares of the nasal cavity, or an ear probe. Even they make small enough probes to be attached to a toe as well. Some of them are battery operated and are portable, so you don't necessarily need to be plugged into a machine. And it's economical. They've gotten a lot more inexpensive as time has gone on, and as technology seems to do. Initially, when they were introduced in the 80s, they were quite expensive, but as time has gone on, the expense has gone down. Okay, so disadvantages kind of goes back to a lot of them from our signal artifact. So if we have poor function if there's poor perfusion, and there's a delayed hypoxic event detection. So by the time, if we have these on our fingers, by the time the fingers detect that by the time that the blood circulating passes through the fingers, the hypoxic event is going on or has been ongoing. Could be anywhere from seconds to minutes. So it's kind of delayed. In GI, I can always tell if my patient is desaturating because the esophagus, if I'm doing an upper, has already started to turn dusky or pale or even blue sometimes before my pulse ox reacts. So I react quicker because I'm looking at next to a core organ, because the esophagus is close to the heart. I can see internally that patient is compromised before the pulse ox starts going down. You can have erratic performance with dysrhythmias, inaccuracy with different hemoglobins, as we said before, inaccuracy with dyes. You can get some optical interference, and that could just be with like artificial light going in. Nail polish and coverings, or false nails, and motion artifacts. If you have a patient that likes to move around, obviously that you're not going to get a good reading. Some useful tips. Fingers are relatively sensitive to vasoconstriction. So like I said, when the fingers are kind of the last indicators of something going wrong with that patient having a hypoxic event. Dark nail polish and synthetic nails, they inhibit the transmission. The detection of the saturation and resaturation is slower peripherally. And one reason why we say should not be placed on the index finger when people are waking up, the first thing that they do is they take that index finger and jam it right into their eye because they're used to rubbing their eyes. Although we'll tell them, don't rub your eyes because you don't want them to get a corneal abrasion. Usually the corneal abrasion may come from the pulse ox probe rubbing right into their eyes. But out of habit, a lot of us still place it on the index finger. Toes actually may be more reliable with epidural blocks because in epidural blocks you have more vasodilation in the toes or in the lower extremities you have more vasodilation. So as arteries are more vasodilated, you're going to get a more accurate picture of what if a hypoxic event is happening. You would see that a lot quicker versus fingers who would probably already be vasoconstricted. The tongue, the cheek, the forehead, they're less affected by vasoconstriction, so they would reflect desaturation a whole lot quicker. Just kind of FYI. So if you had a patient and you were concerned about, some desaturations, if you have a finger probe that's plastic and that can be unwrapped and just kind of made flat, you could place it on their forehead or on their cheek, and you could get a more accurate depiction rather than on the fingers because the fingers are relatively sensitive to vasoconstriction. All right, so blood pressure monitoring. We're going to jump right into that. All right, so corticough sounds. There are a series of audible frequencies, and they're produced by turbulent flow beyond the partially occluded cuff. So when the cuff is inflated, and as we're letting it go down, when we're auscultating, we hear those sounds of the blood flow as it's going back down through the artery and as the cuff is going down because now the cuff is partially occluded than being totally occluded. So phase 1 is the most turbulent or audible sound, so that is our systolic blood pressure. Phase 2, they're softer, longer sounds. Phase 3, they're crisper and louder sounds. Phase 4, they're softer and they become more muffled sounds. And then phase 5 is when the sounds start to disappear, and that's our diastolic blood pressure. If we wanted to calculate our mean, we would take our diastolic pressure plus 1/3 of the systolic minus the diastolic pressure, and that would give our mean blood pressure. Okay, so the limitations to auscultation. If we have decreased peripheral flow, and that could be related to shock or some intense vasoconstriction, we're not going to hear or be able to really auscultate a good blood pressure. If there's changes in vessel compliance, so severe edema or atherosclerotic vascular changes, a sclerotic artery, it's very hard to auscultate or hear any sounds in a sclerotic artery, and especially with a severe edema. An incorrect cuff size. If the cuff size is not correct, well, we're already doing ourselves a disservice because we're not going to get an accurate blood pressure. So it's recommended that the cuff bladder is 40% of the arm circumference and of at least 80% of the length of the upper arm, and it needs to be centered over an artery, not a vein. And obesity, because there's more adipose tissue in the arm, it makes it harder to auscultate and hear the corticough sounds. And as a side note, the corticough sounds are they're hard to hear in children. So typically we don't auscultate blood pressures in children. So because the corticough sounds are difficult to hear, so it's best to do an NIBP, an automated NIBP, to get a blood pressure for them, which is normally what we do if we can get them to sit still long enough for it, because the younger the child is, the more they squirm around or it causes pain to them, so they don't want to sit through it. So sometimes in a toddler, it'd be very rare that you get a blood pressure while they're awake. If you do get one while they're awake, then you've done a great job. All right, so automatic non-invasive techniques. It's based on oscillometry, and so the systolic and diastolic pressures are being calculated by various proprietary algorithms specific to that individual device manufacturer, and the maximum amplitude of oscillations will equal the MAP. And like I said, the systolic blood pressure and diastolic blood pressure, it's calculated from an algorithm. So with these automatic NIBPs, the systolic blood pressure is the least accurate with invasive blood pressure, and the MAP is the most accurate with invasive blood pressure. So if you're comparing it with an arterial line, your MAP is going to be the most accurate. Your systolic is going to be the least accurate with the invasive blood pressure. These studies have shown that automatic NIBPs, they do correlate well with invasive blood pressures in healthy patients. So sometimes you'll see that they're pretty right on the money. But if you're going to have a pressure that's going to deviate the most, it's going to be a systolic blood pressure. However, even though it deviates the most or it's the least accurate, it still would be fairly close. It still would be within some standard deviation of being close. And we'll talk about that standard deviation in the next slide. Atherosclerosis, edema, obesity, and chronic hypertension traditionally produces errors. So you may see a low systolic pressure and a high diastolic pressure. If a cuff is too large, we have a low blood pressure, and vice versa. If the cuff is too small, we'll see a high blood pressure. Now, when I was talking about correlating well with invasive blood pressure in healthy patients, the agreement between the blood pressures, if the patient is older or critically ill, that decreases. So there's less agreement in critically ill patients and in older patients. So you will have less correlation. All right, so our standards here. So each machine, the average difference must be less than plus or minus 5 millimeters of mercury, and even with a standard deviation up to less than 8 millimeters of mercury. However, deviations up to 20 millimeters of mercury are still considered acceptable. So, and they're still acceptable by good performance. So if you are seeing a deviation of up to 20 millimeters of mercury with your NIBP and your arterial line, that's okay. That's totally fine. Which is sometimes what we see, because we don't normally freak out and say, "Oh my God, it's not correlating." If you have if your NIBP is saying 140, but your arterial line is saying maybe like 120, like 125, 130, you're not freaking out. You're not thinking, "Oh my God." That's okay, because that deviation is fine and it's normal. So we do have some problems with estimation. So when a patient is hypertensive, it may underestimate the MAP. And during hypotension, we may have the opposite, an overestimation of the MAP. And then there's also just problems with estimation of underestimating the systolic blood pressure and overestimating the diastolic blood pressure as well in general with the NIBPs. So that's why we look at trending and averaging of all the blood pressures. We try not to just focus on the one blood pressure. We try and look at things over a range of time so we can get a general idea and picture of how our patient is actually doing. So ankle, thigh, and calf cuffs, they actually work very well in patients. Studies have shown that they have worked very well in patients. And they should be used, but however, these have never been validated in obese patients. So probably would not use these particular sites if you had to in an obese patient. The forearm is actually most preferable to the upper arm because you get a more accurate pressure, and it's just easier for the cuff to go on, because sometimes the upper arm is just very difficult because of the large circumference, and for the cuff just to go on well. It may go on better on the forearm. And like I said, the averaging and trending is necessary for measurements to be reliable. Okay, so the advantages, it eliminates clinician subjectivity, and there is improved quality and accuracy over time that's occurred with NIBPs, and the automaticity. It decreases the white coat hypertension incidence. So usually we don't see as much as the patient, when patients are going into the doctor's office, their blood pressure isn't sky high, but we see that I still see that sometimes initially when I'm starting an IV or something, or when I'm initially talking to the patient, and then the subsequent blood pressures are a lot lower. So I guess in certain studies it has shown that white coat hypertension has decreased as well. And it's non-invasive, so we don't have to poke or probe the patient in order to use these. Disadvantages is they're unsuitable in rapidly changing situations. So if you've got a patient that's crashing, an NIBP is not going to help you to actually try and titrate or uh, manipulate blood pressure effectively. It can cause some patient discomfort with pain. Complications can be lead to compartment syndrome and pain, petechiae or ecchymosis, limb edema, venous stasis, or thrombophlebitis, or peripheral neuropathy in certain patients. And the compartment syndrome in a compromised patient, it could just be due to the prolonged periods of frequent cycling, and that's causing trauma or impaired distal limb perfusion in compromised patients. So use with caution in severe coagulopathies, peripheral neuropathies, arteriovenous insufficiency, and patients that have undergone any recent thrombolytic therapy. So invasive blood pressure monitoring, or arterial lines, it's continuous and it's real-time changes. So we can see exactly what our blood pressure is doing, so that allows us to act immediately or titrate and really do effective change. They're indicated if we are going to do some planned pharmacologic manipulation, like in carotid surgeries. We have rapidly changing blood pressure based upon what the surgeon is doing, and we try to keep our blood pressure at a happy place, but sometimes because these patients are so hypertensive and so labile, it's up and down. So you need an arterial line to have that in place. Repeated blood sampling. So if you know that you're going to be doing a lot of blood draws, arterial line is great to have. It's the determination of volume responsiveness, and we'll talk about that through SPV, SVV, and just being able to determine, can a patient do a fluid challenge or be able to be get some volume on board if they are having swings in their arterial pressures. And the timing of balloon pumps, Comter pulsation. So we know that we need to time our balloon with the diacrotic notch in the arterial line. Okay, so monitoring sites. The radial artery is the most common site. It's easy to access, and complications are fairly uncommon. Other sites, such as the ulnar or brachial, those can be used as well, such as and so the axillary, femoral, posterior tibial, and dorsalis pedis, those can be used as well. If you're going to use the brachial or axillary arteries, you need a longer catheter, and you would need a longer catheter because the sites they're relatively deeper and they're more mobile in anatomic locations. The brachial artery does not really have a lot of collateral branches to protect the hand, so that's something to think about. The femoral artery, it's the longest vessel, but you could have some hidden hematoma formation. So because it's right there in the groin, sometimes if people have like edematous or extra tissue there, or just the hematoma can form, and sometimes it's hard to be seen. And there's risk of contamination as well from urine or fecal matter, unless, well, not urine if there's a Foley catheter in, but fecal matter, there's still risk of contamination there. Posttibial and dorsal pedis, they are, so the lower extremity vessels tend to demonstrate greater disagreement with non-invasive blood pressure, so the NIBPs, with the diastolic and the mean measurements being the most affected. So that's just something to think about if you are using a lower extremity for an arterial line for blood pressure. You will probably have less agreement between the mean and the diastolic pressures. So an Allen's test was invented in 1929, and the Allen's test we'll talk about on the next slide. Basically, and that's a test we do prior to inserting the arterial line. And then there was a research study done by Slogoff in 1983. And it was a study that consisted of 1,700 patients, and in those 1,700 patients, only about a quarter of the evidence showed that there was radial artery occlusion after the cannulation, but there was no evidence of ischemia. So, in a study of 1,700 patients, and that evidence shows only about 25%, but still no evidence. So 25% of radial artery occlusion, but however, there's no evidence that's showing the ischemia. It doesn't prove that using the radial artery is unsafe. And that's why we still use it, because it is very safe, and the complications are very uncommon with that artery. Okay, so an Allen's test, it basically is going to attempt to detect if the patient has reduced collateral blood flow. And so initially the examiner compresses the radial and ulnar arteries, and the patient will make a tight fist to exsanguinate the palm, or let the blood flow, remove the blood flow from the palm. And the patient will open the hand after that, and then the examiner, or the person, or you, will release the ulnar artery. And as the ulnar artery is released, we are looking for the color of the palm to return within seconds. Now, if there's severely reduced collateral blood flow, that means if the color returns after 10 seconds. So the book will say if the palm remains pale for more than 6 to 10 seconds, but if it's more than 10 seconds, that's pretty much what it is, because at 80%, there's about 80% accuracy, and that's for a color change at 5 seconds. So if you're looking at 5 seconds and then you just go initially to 6 seconds, it's not a big jump to say, okay, well, 5 seconds it was fine, but at 6 seconds it wasn't. So I would say for something more clear, like if it took at least 10 seconds for the color to return to the palm, then yes, the patient probably has some severely compromised collateral flow. However, the predictive value of this test is poor, because we have seen that there have been reports of ischemic problems with a normal Allen's test, but there's also been reports of normal radial catheter use or harvesting for CABG with an abnormal Allen's test. So in the face of having an abnormal Allen's test and then showing some ischemic problems in the hand, but the test was the Allen's test was normal, it still doesn't really indicate that it indicates that it's about 80% accurate, but it's still hard to say, okay, because of this test and the test was abnormal, that you shouldn't move forward with using using the radial artery. Just use your best judgment, and if you feel like the patient is going to be compromised, then don't do it. Find a different site that works. The use of pulse oximetry or an ultrasound actually doesn't improve the accuracy as well. So you just, when you're going to just put an arterial line in, just use your best judgment. So the technique, and you would, as your patient is laying there, you would prop underneath their hand, on the back portion of their hand, prop their wrist up and tape down their hand so you get full extension, and their arm should be fully extended as well. This patient is on an arm board, and at the bottom you see the arterial catheter or needle with the catheter over, and there's the guide wire. This little black thing right here is the guide wire that you can use to guide you down. Okay, so there's two different techniques you can use. The first one is the Schledinger's technique, And so initially what you'll do is you insert the needle, and this could be to a syringe, but usually I have never done it. I have done it this way only a handful of times, but most places have the arterial lines, the arterial needles and catheters with the guidelines all attached in one nice little package, like I pointed to in the previous slide. Um, After the needle is inserted into the artery and you get a flash, which you remove the syringe, and that's a slip tip syringe. So you would just remove the syringe, and then you would pass the guide wire through the needle, and then you holding the guide wire in place and making sure it's staying stable. You remove the needle, leaving the guide wire in place, and then you use the guide wire to thread the catheter and insert it. And then after the catheter is in place, you remove the guide wire and then you connect it to your arterial line, your transducer, and then you zero and set up your arterial line and zero it, and you would level it and make sure everything is okay. Now, transfixion technique is the same positioning and same preparation. Oh, I forgot to say that this is a sterile technique. It is a completely sterile technique. Now, you may see some people that do not use sterile technique, but it should be a sterile procedure. It is sterile technique. So, same positioning, same preparation. With this, you intentionally go through the front wall and the back wall of the artery. And then and with this, it's usually done with the with an arterial line where the needle and where the catheter is over the needle. So you puncture the front and back walls, and then you remove and withdraw the needle, leaving the catheter in place. And then you slowly withdraw the catheter until you see pulsatile blood flowing through the catheter. Then you know that it's in place. Now, at that time, if you have a guide wire, if you want to use a guide wire, you can use it. You can use the guide wire to redirect and pass that catheter to make sure the catheter is still within the artery. But at that time, if you're seeing a pulsatile blood flow, you're in the artery. But I have seen this done with some people using the guide wire, with some people not using the guide wire. But at the time, if you see pulsatile blood coming out of the artery, you know you're in the artery, and all you have to kind of do is angle it a little bit. But sometimes the catheter can get a little bit flimsy, so that's why some people use the guide wire so they can just kind of reposition and angle it, and then making sure because the guide wire is in place, and all you have to do is just slide the catheter down, because some skin can be thick, can be a little tight to pass through. I know if you've been passing like a IV catheter through some thick skin, sometimes it's a little bit hard to get that catheter through. Now, this particular technique is not associated with more complications, actually, considering. So I don't know why that isn't. You would assume that patients would have a giant hematoma, but I guess the integrity of the walls there, and maybe there's not as much blood that goes into the tissues and that leaks out there. I'm not quite sure, but it's not associated with more complications. So the function of our arterial line setup, it's an automatic flush system, and the patients normally get about 1 to 3 milliliters of saline per hour, and that prevents thrombus formation. There used to be dextrose and used to be heparin included in the pressure bags, but they're not anymore. It doesn't need to be. It's not necessary. Okay, and we zero. And when we are zeroing our arterial line, it references pressures against atmospheric air. So we zero it to the air, as you all know, because I'm sure you guys have all zeroed many of arterial lines in your time. We level it at the aortic root, usually at the mid-chest mid-axillary line. And we try to maximize our waveforms by limiting the number of stopcocks, limiting the tubing length, and using non-distensible tubing. So it's kind of that thicker thicker tubing. It's not traditional IV tubing that's more pliable and more flexible. This is stiffer tubing. So if we, and that gives us, and that minimizes the resonance or the bounce that's in the arterial line. So that gives us a good waveform when we're using the non-distensible tubing, limiting the stopcocks and limiting the tubing length. All right. So with our arterial waveform, we've got 6 different steps, parts of the waveform. And so usually our arterial waveform, it comes right after the R wave. And that's when we see our arterial waveform. And it's the systemic, this waveform results from the ejection of the blood from the left ventricle during systole, and then it's followed by the peripheral runoff during diastole. And so we see this steep systolic upstroke, which is labeled as 1, and then that systolic peak pressure, so that's our systolic pressure, and then we have 3, which is our systolic decline and our dicrotic notch, and then we have our diastolic runoff at 5 here, and then 6 is our end diastolic pressure. And we know the dicrotic notch is from the aortic valve closing. Now, our map is the area that's beneath the waveform. And so it's the area beneath the waveform or the arterial pressure curve divided by the beat period. And it's averaged over multiple cardiac cycles. And so it's something we don't have to calculate. Obviously, the computer will calculate that for us. But we sometimes estimate the MAP as the diastolic pressure plus 1/3 of the pulse pressure. But this is only valid if the patient is bradycardic or has not bradycardic, but has a slower heart rate, because the duration of diastole decreases as the heart rate increases. So if we're not in diastole long enough, when our heart rate increases, that MAP may not be accurate. The estimation of the MAP will not be as accurate. Okay. So with distal pulse amplification, and we talked about that. I know you guys talked about that before. So the arterial pressures are measured at different sites, will have different morphologies, and that's due to impedance and harmonic resonance along the vascular tree. So as we are moving further along from the aorta or from the heart, or from the aorta to further arteries, the impedance and harmonic resonance along the vascular tree is going to show a different morphology of those arterial waveforms. So as the pressure moves to the periphery, we will see an arterial upstroke that is steeper. So you see from the aortic arch to just the short distance from the aortic arch to the femoral artery, it's a steeper upstroke. You see that? And then our systolic peak is a bit higher. Our dicrotic notch is later. You see that it's earlier here and it's later here. And then our end diastolic pressure is lower. As you see that. Our end diastolic pressure here, and then our end diastolic pressure is a lot lower here as it moves to the periphery. All right, so how are our waveforms made? So it's a summation of sine waves, and our fundamental wave plus our harmonic wave equals our typical pressure wave. So that's our summation wave. So the fundamental wave plus the harmonic wave gives our summation of the sine waves, because these are all sine waves. But this particular sine wave is called the fundamental wave. This one's a harmonic wave, and the sum of both of those equals our waveform. So a fundamental wave is known as the pulse rate, and it's a characteristic that's manifested clinically as the pulse rate, and it's expressed as cycles per second or in hertz. And then harmonic waves are smaller waves that have frequencies that are multiples of the fundamental wave. So it's like 2 hertz or 3 hertz. So there are 6 to 10 harmonics that are required to make most arterial pressure waveforms. And this, how we see it, the summation, is through Fourier analysis. It's the analysis of the summation of multiple sine waves. And so thank goodness we don't have to try and calculate it. But so through Fourier analysis, that's how we see it on our monitors, and that's how it's produced. Okay, so our square wave test This is, or our fast flush is what most of us probably know it as. This test provides a convenient bedside method for determining the system dynamic response and assessing signal distortion. So we want a clear, sharp picture because we have seen under and over dampened or very sharpened or jagged looking arterial lines, or ones that are kind of flat, and we have seen those in where we have a lack of a dichrotic notch. And so when we are doing a square wave test or the fast flush test, we are checking to see what's our dynamic response here, and are we having any distortion in our signal. And so when we do the fast flush, and that's when we're pulling our pigtail or we squeezing at the transducer and getting that straight up flush. And then when we release it, following that flush, we shouldn't have any more than 2 oscillations. So that's the bounces that you see here, 1, 2, and then it should go back, and then it should go back into reading the arterial pressure. And the oscillations, they should be less than 30 milliseconds. And the pattern of these amplitudes that we see here should come back to baseline, and they should rest. Now, this is normal because you see a nice dichrotic notch. Everything is easy and visible to be seen. So we moving into the next one, because what I want you to understand basically here is that you should only have less than 2 bounces or 2 oscillations. Then it should go back to baseline, and then it should return back to reading the arterial line. That's what your square wave test in a good arterial line that's properly dampened. That's what you should see. You shouldn't. There's not a lot of resonance in this particular waveform. Now, with underdamping versus overdamping. So this is in under-damped system, and this is an over-damped system. This is an explanation. So all of the arterial lines, the systems have damping capability, and basically think of that as sharpness, and it decreases the system resonance. So it decreases the extra bouncing or extra oscillations in that you could possibly see, like you see here, the extra bouncing. That means this would be a lot of increased resonance in this, hence being an underdamped system. And so, and it prevents exaggerated waveforms as we see here. So when in the underdamped system, we see a systolic pressure that is elevated, and then you have multiple artifacts, so it's kind of hard to see exactly where your dichrotic notch is. So you have an overshoot, your systolic blood pressure is elevated, and it's very hard to see exactly where your dichrotic notch is because you have so much artifact. Your dichrotic notch is here, but you have so much artifact. And then when you do your fast flush, you have about 5, 6, 7 oscillations or bounces afterwards. So we know that this system is underdamped, and the systolic blood pressure is overly estimated. So we would have to do some detective work to try and figure out what's going on here and how we should fix it. And with the overdamped reading, as we see on the bottom, our systolic pressure is decreased. We've lost our dichrotic notch. It's a loss of detail, so our sharpness is gone. And it's a falsely narrowed pulse pressure. So, and this is a falsely elevated pulse pressure, but we have a falsely narrowed pulse pressure here, but our map will still remain accurate. So in an overdamped system, our map will still remain actually pretty accurate. But also, even in an underdamped, the map will still remain will remain accurate. So your blood pressure, it'll be either overly estimated or underestimated, but your mean arterial pressure will remain fairly accurate in both an underdamped and overdamped blood pressure readings. And so when you do the fast flush, you won't even see the oscillations or any bounces. It just goes straight back to baseline. And so you know that it is a overdamped system. And this usually will happen when there's a clot in the catheter tip or an air bubble in the tubing. So you want to try and troubleshoot, or sometimes if the arterial line has if it's on its tail end and it's been in for longer, or about a week or longer, sometimes it's just exhausted and it just needs you need a new site. All right. So we also can have some pressure gradient changes and in our arterial waveform, and you see the differences between the young and elderly. And that's age is due to a lack of distensibility. So we have reduced arterial line compliance, and that causes a extremely rapid return of reflected pressure waves, resulting in arterial pressure waves with increased pulse pressure and a late systolic peak pressure, which is indicated here by this arrow. And you can have an attenuated diastolic pressure wave, and at times an early systolic hump distorting the smooth. Whoa, let's go back. I'm sorry. That's so an early systolic hump that distorts this smooth upstroke. So that's what we see in the elderly. So when atherosclerosis, or if there's some peripheral vascular changes because their arteries are now not as distensible, you'll see this type of waveform in somebody that's older versus somebody that is young. So atherosclerosis causes some changes, peripheral vascular resistance causes changes, septic shock, and hypothermia. And we may see a difference between two arms with vascular changes, because some patients may have sclerotic veins in one arm, or not veins, I'm sorry, arteries in one arm versus the other. Septic shock, you may see if there's a femoral line, the femoral artery pressure may exceed more than the radial pressure by greater than 50 millimeters of mercury, just due to the nature of septic shock. And hypothermia, vasoconstriction, it can cause systolic pressure in the radial artery to exceed that of the femoral artery, whereas during rewarming, vasodilation will reverse the gradient. So hypothermia, you may have a wider gradient, and then when the patient gets rewarmed, that gradient decreases or returns back. Okay, so arterial line complications. We can see distal ischemia or pseudoaneurysm with arterial lines or upon insertion, hemorrhage or hematoma, arterial embolization, local infection, or peripheral neuropathy. Like I said, a lot of complications are relatively uncommon, especially in the radial, in the radial artery, but anything is possible. And so these are the particular complications, as you can see. Patients that have been in the ICU, their catheters tend to stop functioning about a week or two in, and it could be because of arterial inflammation, occlusion, or clot formation. So, and you can see that if you get this very, very, and if the dampening is changing in the waveform, or you just can't get a good reading, or if the site looks bad at the skin, it's time to just DC that site and get a new site. Okay, so pressure waveform analysis, and so this is going to essentially identify the presence of residual preload reserve. And when we want to attempt to see if we need to hemodynamically resuscitate a patient, we need to make sure they have adequate preload reserve, meaning like if we give them a fluid bolus or if we give them a fluid challenge, do they have enough reserve to respond well to that fluid challenge? And so we can see some cyclic variations in arterial blood pressure due to respiratory-induced changes in intrathoracic pressure, and that's during positive pressure ventilation and lung volume changes. And so we will talk about these next. Okay, so positive pressure effects on positive pressure ventilation effects on pressure. So during the inspiratory phase, we have an increase in intrathoracic pressure, which simultaneously decreases left ventricular afterload, which causes an increase in total lung volume. This displaces pulmonary venous blood into the left side of the heart, which increases left ventricular preload. As left ventricular preload increases and left ventricular afterload decreases, we have an increase in left ventricular stroke volume, cardiac output, and systemic arterial pressure. Okay, and then so with this increasing intrathoracic pressure, our systemic venous return decreases and our right ventricular preload decreases, which alternately causes an increase in right ventricular afterload by an increase in PVR. And so our right stroke volume drops during the early phase of inspiration. Okay, so all of this all of this that is occurring, the big takeaway from this is that our right stroke volume drops during the early phase of inspiration. Okay, so on the expiratory side of things, the situation is reversed. So we have a decreased right ventricular stroke volume that travels through the pulmonary vascular bed to enter the left heart. So we have reduced left ventricular filling, decreased left ventricular stroke volume, and a decrease in our systemic arterial blood pressure during the expiratory phase. So this cycle of increasing and decreasing stroke volume and systemic arterial blood pressure in response to end expiratory pressure is known as SPV, which is systolic pressure variation. And so in our mechanically ventilated patients, a normal SPV is anywhere from 7 to 10 millimeters of mercury. Now, remember, this is only in mechanically ventilated patients. If your patient is spontaneously breathing, this is not the same because there's not positive pressure ventilation. It's in a patient that's receiving positive pressure ventilation. But your normal SPV is 7 to 10 millimeters of mercury. So in positive pressure ventilation, our systolic blood pressure increases on inspiration and it decreases on expiration, which we just talked about in the previous two slides. And we measure the increases. We measure the changes in the delta up and the delta down, and we measure those differences. So a normal delta up, in which we measure here, our delta up is 2 to 4 millimeters of mercury, and going down to and this is on our inspiratory pressure, peak inspiratory pressure, and expiratory pressure here. This is our delta down, and our normal delta down is 5 to 6 millimeters of mercury. And so we look at the difference between those, and if it's greater than 10, an increased SPV, then we know that this patient is going to be volume responsive, or have residual preload reserve, meaning that they have enough reserve that they could tolerate having some fluid given to them to try and to reduce this delta up and delta down changes and reduce this swing that we see with positive pressure ventilation. And so this is also a possible early indicator of hypovolemia in patients. I'm not saying that it is the primary indicator of hypovolemia, but it's a possible early indicator of hypovolemia. And in a critically ill patient, you will see a dramatic increase in the SPV, so greater than 10, and it's usually the delta down component that you're going to see that biggest change in. Okay, so we'll also talk about pulse pressure variation, and so this is also an indicator of preload reserve as well. And so this utilizes a maximum and minimum of pulse pressures over an entire respiratory cycle. and normal is anywhere less than 13 to 17%. If the patient has a pulse pressure, a PPV or a pulse pressure variation greater than 13 to 17%, they will have a positive response to volume expansion. So that means they have enough preload reserve to tolerate fluid. And so you are taking the difference between the maximum, your pulse pressure maximum, and your pulse pressure minimum, and you take that difference, and if it's between 13 and 17% or lower than that, that patient is normal. But if it's greater than 13 to 17%, that patient could tolerate a fluid challenge or could have a positive response to fluid to volume expansion. The maximum difference in arterial, and also it looks at the maximal difference in arterial pulse pressure, and it's divided by an average of maximum and minimal pulse pressures. But luckily, we don't necessarily have to do that because a lot of our machines can actually calculate a pulse pressure variation. But if you wanted to, you could print out an arterial line tracing over an entire breathing cycle, and you could calculate it yourself if you would like to. Now, with pulse pressure variation, there's a gray zone that's been described, and that's usually between 9 and 13%. So if your patient falls within that zone, they're just fine. They don't need any volume expansion. But however, if somebody does fall above 13%, they should receive volume expansion. And if they are below the 9%, they don't need anything. But like I said, any normal is less than 13 to 17%. I don't know why that range is 13 to 17. I guess I'm assuming that research has stated that is the appropriate range, but 13 and 17%, that's what you should know. And so above 13 to 17%, they will have a positive response to fluid volume expansion, or not fluid volume, just volume expansion. Okay, so stroke volume variation, it's a computer analysis of arterial pulse pressure waveforms, and it correlates resistance and compliance based on age and gender, and it computes the stroke volume. And it's so your stroke volume max minus your stroke volume minimum divided by the stroke volume mean. And normal is between 10 and 13%. If the patient is greater than, the calculation comes out to be greater than 10 to 13%, there is a positive, the patient will have a positive response to volume expansion. So this is also an indicator of preload reserve. All right, so predicting accurate results. So to use these and to predict accurate results, the patient must be mechanically ventilated with a tidal volume of 8 to 10 milliliters per kilo. And they must have a PEEP or a positive end expiratory pressure that is greater than 5 millimeters of mercury, and a regular cardiac rhythm, and a normal intra-abdominal pressure, and a closed chest. So there shouldn't be any chest tubes or patient having a CABG or their chest wall open, or if there's a belly surgery or belly case going on, their belly should not be open, so you could not calculate this as well. Or if a laparoscopic case is going on, because you're increasing the intra-abdominal pressure there through insufflation, you could not do this as well. Now, a regular cardiac rhythm, they need that, and a positive end expiratory pressure of 5 millimeters or greater. 5 millimeters of mercury or greater, and mechanically ventilated with a tidal volume of 8 to 10 milliliters per kilo. So this patient has to be mechanically ventilated to calculate the most accurate results. Okay, so the importance of all of these calculations is it's based upon Frank Starling, and we know Frank Starling is looking at contractility and as it relates to stroke volume and preload. And so our preload reserve describes a physiologic state in which our volume expansion or fluid challenge would shift the patient upward on the Frank Starling curve which would which would result in an increased stroke volume and an increased cardiac output, as long as the SVR, the systemic vascular resistance, doesn't change. So, if there is a lack of variation after you calculate this, and there's a lack of variation, meaning that it's less than the 10% or it's less than the 13%, then that means that patient is going to be here on this flat portion of the curve, and they would not be volume responsive. Now, if the patient is greater than that 13%, or greater than the 9%, depending on, let's see, I'm sorry, not 9%, greater than I was thinking of the stroke volume variation, but it's 10 to 13%. But if they're greater than that 13%, if they're going to be on the lower end of this curve, on this diagonal, meaning that they could tolerate some fluid. And when you give them that fluid challenge, when you increase their preload, you're going to increase their contractility, and you're going to increase their stroke volume. So they'll go from here to here, and hopefully higher up on this portion of the curve until they reach this flat portion, meaning that there is no variation and they have an adequate preload reserve. Okay, so moving right along, next to is expired gas analysis. Okay, so sampling sites, these are just various sampling sites, as you can see, and this basically in your breathing circuit right at your Y piece, your elbow right here that connects to your mask, and to a face mask. Some of these have sampling sites lines built right in. This one is taped. Sometimes we get creative in anesthesia, and then a nasal cannula that more than likely has a sampling line that's built into it, and that just so meaning that we can monitor our end-tidal CO2. All right, so our gas sampling systems. So we our sampling lines, our sampling systems, they basically sample our gas mixture, and analyze it. And the gas must be brought to the analyzer, and it's via either side stream or diverting analyzer. A side stream CO2 monitor, it takes gas from the circuit, away from the patient, from the breathing circuit, to a monitor or to an analyzer to monitor, while a mainstream will analyze the gases right in the breathing circuit. And so a side stream is also called a diverting analyzer, and a mainstream is also called a non-diverting analyzer. An example of that would be a fused cell oxygen analyzer, which analyzes oxygen right in the breathing circuit itself. So we look at total response times. And with this, we're looking at the total response time that it takes to get the gas to the monitor or the place where it's being analyzed, to and looking at like how long it takes to travel to get there and how long the analysis takes. And so the transit time is the time lag for the gas sample to actually reach the analyzer, and you would see that mostly in the side stream. And the rise time is the time that it takes the analyzer to react to the change in gas concentration. So that'll be a little bit longer in the side stream versus the mainstream, because the mainstream will analyze right in the airway versus the side stream having to monitor outside of the airway. The side stream responses are dependent on the sampling tubing inner diameter, the length, and the gas sampling rate. All right, so there are some sampling challenges. And so with the mainstream, water vapor can accumulate, and secretions in blood as well. It can accumulate right there on that analyzer, and so that could distort the analysis. And there's more interfaces for disconnections, because it's right there, usually like right at the Y piece or within the breathing circuit. And so when it is connected at the Y piece, sometimes there's the EP tube, the analyzer, and then the Y piece of the breathing circuit. So in the past, it used to be very heavy, and it used to also sometimes create burns because it used to get really hot and heated when it was being used. But it doesn't get hot now because the technology has changed and now they're lightweight. But it is prone to have more disconnections because you connect at the end and at you connect at both ends. Side stream, there can be kinking of the sampling tubing, water vapor, so water can accumulate within the sampling tubing as well. Failure of the sampling pump that pulls out the sample. So if the sampling pump fails, then we can't pull out our sample via the tubing from the breathing circuit to be delivered to the analyzer to be analyzed. There could be leaks in the line, and there could be a slow response time, which is normal, or even slower response time, because there could be just time lag. All right, so Dalton's law, and so with just a quick review of Dalton's law and the units of measurement. So Dalton's law is essentially the total pressure that's exerted by a mixture of gases is equal to the sum of the partial pressures that is exerted by each gas within the mixture. So at sea level, total pressure of all anesthetic gases within the system are at 760 millimeters of mercury. Excuse me. And gases are expressed as partial pressure in millimeters of mercury or volumes percent. So, for example, oxygen in room air. Now, off the top of our heads, we probably all know that it's about 21%. But we would look at the partial pressure of oxygen, which is 160 millimeters of mercury. We would take that 160 millimeters of mercury and divide it by the atmospheric pressure within this, not atmospheric pressure, I'm sorry, the total pressure of all the anesthetic gases within the system within our anesthesia machine. That's at 760 millimeters of mercury, and then we'll multiply it by 100. That would give us volumes percent. If we didn't multiply it by 100, then it'd just be the 0.21, which is sometimes what we are all which is what we all normally see. So it's the partial pressure of the gas, of a particular gas, divided by the total pressure of all the gases, and you multiply that by 100% or 100, and that would give you it in volumes percent. If you did not want to multiply it by 100, it'd just be in the decimal format. Okay, so how are these all analyzed? So mass spec or mass spectrometry is how it used mass spectrometry and Raman spectrometry. A spectroscopy is how the gases were analyzed initially. Mass spec you may see is if you run across some very, very old anesthesia gas machines, you may see mass spec, but most of the time you won't. You'll see just infrared analysis, which is what we'll talk about in the next slide. But mass spec, it basically essentially it looks at the concentration. The concentration is determined according to the mass charge ratio, and it's looking at how many molecules of each gas sample or each gas are present in the sample. And so there's an abundance of ions at specific mass charge ratio, and that's determined and it's related to the fractional composition of the gas mixture. So the mass spec or the mass spectrometer basically allows the identification and quantification on a breath by breath basis of up to 8 different gases, the identification of up to 8 gases, and it can identify oxygen, nitrogen, nitrous, halothane, enflurane, and isoflurane. And it also can identify helium, SIBO, argon, and desflurane as well. Now, the Raman spectroscopy or Raman scattering, it's a high-powered or consists of a high-powered argon laser that produces photons that collide with gas molecules in the gas sample. And those photons that it creates, they scatter. And then they're measured in a spectrum that identifies each gas and its concentration. It's no longer in use. but those scattered photons are exactly how it would identify the concentration of each particular gas within the sample. Okay, so infrared analysis is most common. That is exactly what we'll see most commonly now. And so it's the measurement of energy absorbed from a narrow band of wavelengths at infrared radiation as it passes through a gas sample. And I have a picture of kind of what that would look like. And so it measures the concentrations of gases. It's non-dispersive infrared analyzers are the most common. So there's dispersive and non-dispersive, but non-dispersive infrared analyzers are the most common that are used within anesthetic gas machines. It measures CO2, nitrous oxide, water, and volatile anesthetic gases. O2, so oxygen, does not absorb IR radiation. So mass spec could analyze oxygen, but infrared analysis does not analyze oxygen. So we have these asymmetric polyatomic molecules of various gases, and they absorb the infrared light at specific wavelengths, and those wavelengths pass through a band of IR radiation, and then the concentrations are measured, and when those concentrations are measured, the light goes toward the detector, and then we get a readout of the concentration of each of our gases within the mix. Okay, so each gas has a unique IR transmission spectrum absorption band, which is essentially a fingerprint, quote unquote. And so the strong absorption of IR light occurs at specific wavelengths for each gas. So, for example, CO2 is measured at 4.3 microns. You don't need to know that. But that's just an example of like how different wavelengths, each gas will have different wavelengths. And then the IR light is transmitted through the gas sample or a gas sample over a range of frequencies, and then it's filtered through a narrow band pass filter. So as our gas sample goes in, and then it goes through these filters here, and then these detectors say, oh, there's a concentration of CO2 in, nitrous or SIVO or desflurane, and then we get that readout on our monitor, and we can see exactly what the concentration is. So we have the IR light that's passing through. And so the amount of light that reaches the detector is inversely related to the concentration of the gas that's being measured. So if we got less light going through, we have higher concentration. So think back to when we were talking about our pulse oximeter, and if there was like a higher concentration of the hemoglobin cells and the wavelengths could not get through to the other side, same principle. So if less light is going through this band filter here, if less light is getting through this gas sample, then we know we have a higher concentration of our particular gas. So water vapor. So side stream analyzers report ambient temperature and pressure dry, ATPD values, and so meaning when it's taking the gas sample, it takes the water comes out of the gas sample, so it's essentially a dry sample at that point, and the water gets wicked off and it goes into a water trap. You'll see these on the anesthesia machine if you hadn't seen it already. And so, but the recommendation is that analyzers should report the results at body temperature, pressure saturated values, which is our humidified values that basically come from our airways. And so as we breathe in or we take in a gas sample, we are automatically humidifying it and heating it up, creating water vapor, and because it's going into a warm heated area that's warmer than the atmospheric temperature. So we are creating the water vapor as we are breathing in, because the atmospheric gas is cooler than body temperature. And even though that atmospheric gases, it may contain some water, it's rarely 100% saturated. But inspired gases, as we breathe in, they enter in the upper portion of our respiratory system. They're rapidly warmed to body temperature, and it becomes fully saturated at a partial pressure of 47 millimeters of mercury. So we have added water vapor to our gas sample. We have added water vapor as we breathe in atmospheric gas, or as we breathe in gas. And so the take-home point from this is that in our ventilated patients, we, instead of starting at 760 millimeters of mercury, we need to take away that 47 millimeters of mercury. And our ventilated patients, their total gas pressure starts at 713 millimeters of mercury. So if you wanted, for instance, if you wanted to calculate the partial pressure of O2 in a patient that is 30% oxygen, what you would do is you would make sure from the total pressure of 760, you subtract the 700. You subtract the 47 millimeters of mercury, and that gives you 713. Then you would multiply that by 0.3, and that would give you the 214 millimeters of mercury. So that would be your partial pressure in that particular patient. Your partial pressure of oxygen, 30% oxygen, is equivalent to 214 millimeters of mercury in a patient that is ventilated, because we have to take out the water vapor, because they have water vapor that is saturated at 100, basically they get water vapor that is saturated, so we have to take away that water vapor, and we have to account for that. So that's the big takeaway point. Okay, so oxygen analyzers, there's two common ones. There's the fuel or galvanic cell, or the paramagnetic. So the fuel or galvanic cell is an oxygen battery that measures the current produced when oxygen diffuses across a membrane. And the current is proportional to the partial pressure of oxygen within that fuel cell. The fuel cell is a sensor that is covered by an oxygen permeable membrane and is exposed to the gas in the breathing circuit. And so remember, this is the oxygen analyzer that's mainstream, that's right in the breathing circuit. This is the one that analyzes right in the breathing circuit. They generally have a short lifespan, so usually months. And it's usually depending on the length of oxygen exposure. So if usually you can take them off and just turn them off because they're battery powered. But if somebody forgets, and a lot of our our circuits are disposable, so some people may throw them away inadvertently if they're not used to having mainstream analyzers. It has a slow response time, and it's usually approximately about 30 seconds. So it's best to monitor oxygen concentration in the inspiratory limb versus the expiratory limb, because with the expiratory limb, we generally, as CRNAs, we want to see exactly what's going on very quickly. So it's best for this particular oxygen analyzer to monitor O2 concentration in the inspiratory limb. All right, so the paramagnetic oxygen analyzers. So with these, the oxygen is a highly paramagnetic gas due to the magnetic energy of the unpaired electrons in their outer shell orbits. So how this works, a change is detected in the sample line pressure resulting from the attraction of the oxygen that is being switched by switched magnetic fields. The signal changes during the switching correlate with the O2 concentration. These paramagnetic oxygen analyzers are used in most side stream sampling multi-gas analyzers, so they're commonly used in most of our anesthetic gas machines now. And they have a rapid breath-by-breath response. And rapid breath-by-breath monitoring capability. So they're extremely fast versus the fuel or galvanic cell oxygen analyzers. So oxygen monitoring, The oxygen monitor is probably the most important monitor of all, and it must be calibrated for high and low oxygen concentrations, which we'll talk about the alarms that go off for the low and high concentrations here in a second. So they're sampling inside of the inspiratory limb and inside of the expiratory limb. And I apologize, the insured oxygen delivery, like on this PowerPoint, on my PowerPoint, shows that it's not indented over, but it should be indented over. So because when it, because the oxygen analyzer samples gas in the inspiratory limb of the breathing system. This provides the only means of ensuring that oxygen is being delivered to the patient. And if a hypoxic gas or gas mixture is being delivered, the alarm will be enunciated inside the inspiratory limb. So this lets us know that we're delivering a gas mixture that's not hypoxic. And then with sampling inside the expiratory limb, we get to make sure that the patient is completely pre-oxygenated as we are getting ready to prepare them for induction. And that's when we are having them take those big, deep breaths in and out to completely remove the nitrogen from their lungs. And we can see this with our end-tidal O2 concentration. And when it's above 90%, although we're giving 100% oxygen, that's totally fine because at least 5% of that difference of the 10% is end-tidal CO2 that's being breathed out. So an end-tidal O2 concentration that is above 90% is totally adequate for our patients. So if we are not necessarily intubating or using an LMA and using a breathing circuit to ventilate or monitor our patient, if we are using auxiliary sites such as a mask or nasal cannula that is connected to the auxiliary oxygen flow meter or oxygen outlet of the anesthesia workstation, that we can't monitor essentially like the mixture or the concentrations of that oxygen. The only thing that we could monitor is end-tidal CO2 if we have a sampling line attached to that cannula or to that face mask. And then we can connect it to the CO2 monitor sampling site if it's for a side stream. But beyond that, we can't monitor anything else. We can't monitor the oxygen concentration. So the low O2 alarm, it alerts us to pipeline crossover. So, for instance, if the nitrous is connected to the oxygen and vice versa, when we turn on our oxygen, it'll alert us that we have a mixture that's less than 25%, or our patients are getting less than 25% of oxygen. Or if we have incorrectly filled tanks, so like nitrous in an oxygen tank or vice versa, or failure of the proportioning system, where the proportioning system allows us where our proportioning system, it allows us to go down to a specific proportion of a ratio of oxygen for any other, including in any other, while we're giving another gas. And if that proportion system fails, then we know that a hypoxic mixture is possibly being given to the patient, or we have no oxygen, or we've lost oxygen. And that'll alert the O2 alarm. High O2 alarms, these are necessary, or these high oxygen concentration alarms. These are important when caring for infants or patients that are getting treated with chemotherapeutic drugs who are susceptible to oxygen toxicity. So premature infants, not good for them to have excessive high concentrations of oxygen, or for patients that are getting chemotherapy drugs. Okay, so air pressure monitoring. I'm jumping right on into that. And so this is a key component in measuring ventilation. It's non-invasive, and it assesses mechanical or spontaneous ventilation. It detects circuit disconnections and ETT occlusions or endotracheal tube occlusions, kinking in the inspiratory limb, fresh gas, hose kink or disconnection, circuit leaks, sustained high circuit pressure and high and low scavenging system pressures. Mechanical pressure gauges. So a lot of the old anesthesia machines probably did have mechanical pressure gauges. Some of your newer machines may have, but most of them are probably electronic or digital now. So these require no power. They're always on, and they have a high reliability because they're mechanical. But the downside of that is that they don't record data. There's no alarm system, and you must continually scan them. So you must watch them all the time because there's no alarm that'll alert you that something is wrong. Now, the electronic pressure gauges, they're built right in. They're digital, so they're built in within the ventilator or the anesthesia machine, and there is an integrated alarm system, and they're very sensitive to small changes. So 9 times out of 10, unless you are working at an older facility that has just an antiquated or older anesthesia gas machine, which you may run across, I know I have certain times, plenty of times. So you may see the older mechanical pressure gauges. So the different types of pressure alarms are the breathing circuit low pressure alarm. So this is required by the AANA and ASA standards. The primary purpose of this one is to identify of circuit disconnection or leaks. And so this, however, does not detect some partial disconnection. So it's usually just detects like a full-blown disconnection. So like if your Y piece comes off your ET tube. And this will most likely will not detect misconnections or obstructions. So that's when you just have to be vigilant and just making sure you're like walking back through your circle system and looking through everything and making sure that you are being vigilant and just looking, and just because you never know what could occur. It monitors the airway or circuit pressure and compares it to a preset low pressure alarm limit. And the low pressure limit should be set just below the normal peak airway pressure to alert you of any problems. And so 70% of the disconnections occur at the Y piece. And because that's just it's a normal connection, because that's the connection that you make the most. If you have to disconnect to suction the ET tube or, something of that nature, you disconnect for a second, it'd be more common there than anywhere else within the circle system. Okay, and so the sub-atmospheric pressure alarm, it measures and alerts against for negative circuit pressure and potential of reverse flow of gas. Negative pressures can cause pulmonary edema, atelectasis, and hypoxia. So, and the causes of these negative pressures could be active suction or scavenging system malfunction. So, scavenging systems, they use suction, and if the suction is too high that the scavenging system is using for some reason, that could cause negative pressures. If the patient inspiratory effort, if they're breathing against a blocked circuit, so if they're breathing against something that's obstructed, that can cause negative pressure. And so, for instance, the greatest explanation that I use about this is like breathing against a closed glottis. So, someone that is having a spasm, vocal cord spasm, and their vocal cords are shut, and they're trying to breathe or pass air through a closed glottis or a closed vocal cord opening, they would be at risk for negative pressure-induced pulmonary edema. Inadequate fresh gas flow and suction that to a misplaced NG tube or OG tube. So somehow if the suction has, if the NG tube or OG tube has passed down through the vocal cords alongside the ET tube rather than passing down the esophagus, that could lead to some negative pressure that could cause the pulmonary edema or the hypoxia. And it sounds outrageous, but it obviously has happened because we're reading, we have learned about it. And moisture, excess moisture in the CO2 or soda lime absorbent. So these are things that could set off the sub-atmospheric pressure alarm. Now, high pressure alarms, these are activated if the pressure exceeds a certain limit, And these are user adjustable or automated, and they're valuable in pediatrics. Like I said, because you the with peds, there's certain things that they can't have, and you want to make like so you want to adjust the pressures because their inspiratory pressures and their peak pressures are not going to be the same as adults because they don't have the same anatomy as adults. So that's why this is valuable in pediatrics because you want to be able to adjust the pressure limits accordingly for these patients. The causes of these high pressure alarms are obstructions, reduced compliance, coughing or straining, a kinked ET tube, or endobronchial intubation. And that's a big cause of it. So, actually, if you had your high pressure alarms on and you tried to ventilate a patient, or if you were even bagging a patient, or if you tried to ventilate your patient and it was before you moved back your ET tube, you would hear that high pressure alarm because you'd be in the bronchus and you wouldn't be able to deliver an adequate pressure because you're in the bronchus and normally down the main stem. Okay, so a continuing pressure alarm, and it's when just the pressure just continues. It's triggered when the circuit pressure exceeds 10 centimeters of water for greater than 15 seconds. So when the pressure just is ongoing, not necessarily high pressure, but when the pressure is just ongoing. And so fresh gas continues to enter the circuit, but it can't leave. So somehow it's obstructed. And the causes are a malfunctioning APL or adjustable pressure relief valve, scavenging system, occlusion, activation of the oxygen flush system, or a malfunctioning PEEP. So essentially, with the continuing pressure alarm, the rate of the rise of the circuit pressure depends on the fresh gas flow rate. So if you have like a high fresh gas flow rate, the pressure in the circuit that's occluded or a circuit that's blocked for some reason, like one of the reasons that I said previously, that would cause a continuing high pressure alarm. So if you have a high fresh gas flow rate, or the fresh gas a fresh gas flow rate, and it continues to enter the breathing circuit, but it can't exit, that's going to trigger this continuing pressure alarm. Okay, so now we are on to peripheral nerve monitoring. We're about 2/3 of the way done, guys. All right. So there's two types. There's electrical and magnetic, and electrical nerve stimulation is most commonly used. Magnetic is less painful and there's no physical contact, but it's not used in clinical practice because it's bulky, it's heavy, there's no train of force stimulation, and it's just difficult to achieve super maximal stimulation. And so the supramaximal stimulation, as a review or a refresher, is the reaction of a single muscle fiber to a stimulus that follows an all or nothing pattern. And the response of the whole muscle depends on how many muscle fibers are activated. So if you want to see a really big reaction in the muscle, hopefully you have more muscle fibers activated versus only activating one. You would have just a smaller reaction. We also, with electrical nerve stimulation, sometimes we have to use monitors. And so the monitors provide stimulation and measure the evoked muscle response. So the big thing about monitors, they can do both. They can provide the stimulation, but they can measure the evoked muscle response as well. With sites of nerve stimulation, you want to pick sites that are easily accessible, allow quantitative monitoring, and avoid direct muscle stimulation. The ulnar nerve is the gold standard for nerve stimulation. Now, other places that could be used as well are the median, posterior tibial, common peroneal, and facial nerves as well. The ulnar nerve, adductus pollicis, that muscle is easily accessible. and it has the lowest risk of direct muscle stimulation. Now, the facial nerve, orbicularis oculi, and facial nerve, corrugator supercilii muscle can be assessed easily also when the arms are unavailable. With the ulnar nerve, you'll see some abduction when it's stimulated, and then with the orbicularis oculi, you would see eyelid closure, and with the corrugator supercilii, you would see wrinkling of the brow. The diaphragm is the most resistant to the polarizing and non-polarizing neuromuscular blockers. So there's a shorter onset than the adductor pollice, but it recovers quicker than the peripheral muscles. So it's the last thing that wants to be paralyzed, and it recovers quicker than the peripheral muscles. So a lot of the times when you're recovering your patients, they may get back breathing first, but they still may be weak, like they don't have a good hand grasp, but they're breathing fairly fine. So that lets you know that their diaphragm recovers a lot faster than the peripheral muscles. The corrugator supercilii reflex basically. So in regards to the corrugator supercilii over the adductor pollice, the corrugator supercilii reflects the extent of neuromuscular block of the laryngeal, adductor, and abdominal muscles better. So if you were stimulating at the facial nerve corrugator supercilii, it would when you look at its stimulation over the adductor pollice, you would know that the neuromuscular blockade of the laryngeal muscle or the laryngeal adductor and the abdominal muscles have recovered better by looking at the corrugator supercilii over the adductor pollice. Okay, so single twitch, it's the earliest. It's the earliest pattern and the simplest pattern that was introduced into anesthesia. And so it's a single stimuli that's applied from 1.0 hertz, so 1 hertz every second, to 0.1 hertz, which is every 10 seconds. You need a reference value prior to blocking the patient. So as you get the patient off to sleep, but prior to giving the neuromuscular blocker, you need to see a reference value. So you need to see what is their response to that single twitch. And in order to actually see their response, you need a monitoring device with this particular type of stimulation. This is not necessarily used in anesthesia often at all, or even rarely. But you do need a monitoring device to measure the evoked muscle response with a single twitch. Train of 4 is the most common one that we use, and it's less painful out of all of the particular types of stimulation that we do for neuromuscular blocking. So it provides reliable information throughout all phases of neuromuscular blockade without monitoring device. It gives out 4 supermaximal stimuli every 0.5 seconds. And we evaluate the train of 4 count or fade in the muscle response. So we also look at a train of 4 ratio. So that's dividing the fourth response by the first response. The first response is typically going to be the higher response in the train of 4, with the fourth response being the lowest. So like you see in the picture, you would divide the fourth response, which is B, by the first response, and that gives you your ratio. So in a partial non-depolarizing block, the train of 4 ratio decreases, you see fade, and is inversely proportional to the degree of block. So in like ROC or VEC, a non-depolarizing block, you could see fade, and you could see inversely the inversely proportional. It's inversely proportional to the degree of the block. In a partial depolarizing block, you don't see fade. The ratio is 1-to-1. So when you give sucks, basically the first twitch is going to match the last twitch, or the first response is going to match the same the fourth response. If you do see fade, that's a phase 2 block has developed, and we'll talk about that in a couple more slides. Trainer 4 is a reliable. It's very reliable of onset. It's a reliable assessment of onset and moderate blockade. So if someone has deep or intense level of neuromuscular blockade, Trainer 4 would not be the best one to assess or analyze that. And we cover these definitions in a few slides, so you can kind of see what's the difference between an intense or deep level or moderate blockade. But Trainer 4 is best for just to kind of do an assessment of the onset of neuromuscular blockade and moderate blockade. But if you have a deep or intense neuromuscular blockade, Trainer 4 would not give enough stimulation to try and see what's going on. Okay, so double burst stimulation, there's 2 short bursts of 50 hertz of tetanic stimulation that's separated by 750 milliseconds with 0.2 milliseconds duration of each square wave impulse in the burst. So a double burst 3-3 mode, there's 3 impulses in each of the 2 bursts. A double burst 3-2 mode, the first burst has 3 impulses and the second has 2 impulses. 2 short muscle contractions with fade in the second burst. And so the first of those 2 short muscle contractions is the comparison. So this one, remember, it's not used as much in double burst stimulation, which you may or may not have talked about. I'm not quite sure. I would assume that you guys have talked about that at least in Pharm and possibly with Dr. Schmidt. But so double burst is one of those that isn't used as much. So tetanic stimulation. Tetanic stimulation, it is given at 50 hertz for 5 seconds. And so with non-depolarizers, there's 1 strong sustained muscle contraction with fade after stimulation. So you see 1 really strong muscle contraction, and then you would see like a Trainer 4 fade. But it's not necessarily Trainer 4 because you get there's more than 4. Scratch that. So with tetanic stimulation is given at 50 hertz for 5 seconds. And then with non-depolarizers, there's 1 strong sustained muscle contraction, and then you see fade after the stimulation. And with the depolarizers, you see a strong sustained muscle contraction without fade. If you do see fade, a phase 2 block has occurred. This one has limited value for assessing recovery, and it's very, very, very painful because it's given you're giving a large tectonic stimulation and holding it for 5 seconds, and so you can't really assess recovery very well with this one. And it's not used as frequently as well. Just as double burst is not used as frequently in clinical practice. All right. So post-tectonic stimulation, and so this is a composite stimulation pattern. So you get the tectonic stimulation with the 50 hertz at 5 seconds, followed by 10 to 15 single muscle twitches, about 1 hertz after 3 seconds post-tectonic stimulation. So the response is dependent upon the degree of blockade, the frequency and duration of tectonic stimulation, the length of time between the end of tectonic stimulation and the first post-tectonic stimulus, the frequency of the single twitch stimulation, and the duration of single twitch stimulation before tectonic stimulation. So this one is a good assess. It can assess a deep and surgical blockade. So it would definitely be able to assess those deeper than what a train of four can facilitate, or what train of four stimulus can assess. The post-tetanus stimulation can do more. And you should not perform this more than every 6 minutes, because the with the post-tetanic potentiation, because that's what this tetanic stimulation is based upon, you have this exaggerated release of acetylcholine that shifts the ratio of acetylcholine to neuromuscular blocking agents at the motor end plate in favor of acetylcholine. So you have a big release of acetylcholine. And so that's going to give you that giant muscle contraction. And depending on how much neuromuscular blocker is there, you'll see the fade with that, or you'll see fade in those twitches depending on how much neuromuscular blocker is there. However, but you should only do that every 6 minutes, because you got to give time for another release of acetylcholine to be available at the motor end plate. Okay, so moving right along. So the non-depolarizing blockade. These are the measurements for that. So intense, that's a period of no response, which is about 3 to 6 minutes after the intubating dose of a non-depolarizing neuromuscular blocker is given. So neostigmine is reversible during this time, neostigmine reversal is impossible during this time, and a high dose of Sagamedex at 16 milligrams per kilo has been indicated for reversal. For deep blockade, absence of a train of four, but there's presence of at least one response to the post-tetanic count stimulation, which was the previous one that we talked about. Neostigmine reversal is still usually impossible, but a dose of Sagamedex at 4 milligrams per kilo can be used for reversal. Moderate, so at this point you can see a train of four, and there's gradual return of the four responses to the train of four stimulation. Neostigmine reversal is possible after you have 4-4 train of four. So not one of four, two, or three, but after you have all four of your twitches. And you can give a dose of Sagamedex of 2 milligrams per kilo for reversal. Okay, so phase 1 blockade. So there's no fade or no tetanic stimulation, and you do not see any. There's no post-tetanic facilitation that occurs, and that is what we were talking about with the in the post-tetanic stimulation, where you're basically stimulating to having that exaggerated release of the acetylcholine. So all four responses are reduced, but yes, they're equal. And then they all disappear simultaneously. So in the train of four, so the ratio is 1-to-1. So your first twitch is the same as your last twitch. And there is normal plasma cholinesterase activity in these patients as well. Phase 2 blockade, so there is fade present in response to the train of four and tetanic stimulation. So, and there's also occurrence of post-tetanic facilitation. The response is similar to a non-depolarizing blockade. So, in a patient that you've given Sux to, and if they have fade, where their first twitch is the strongest and then it fades down, whereas the fourth twitch is the weakest, then that's a phase 2 blockade. And so this is indicative of an abnormal plasma cholinesterase level, or abnormal plasma cholinesterase activity. Okay, so in clinical use, so when you're doing neuromuscular blockade, you want to make sure you're keeping the patient warm so you prevent delaying nerve conduction, because when you're trying to stimulate a patient and you're trying to stimulate a cold patient, the nerve conduction is going to go a lot slower than in a patient that's warm. If you're going to use a monitor or a stimulator that has electrodes, you want to attach the electrodes prior to induction and then turn it on after the patient is unconscious. Moderate levels of blockade is sufficient for surgery with 1 to 2 responses for train of 4. So if you've got 1 to 2 of your 4 twitches, that's usually enough for the surgeon to do his work. So they don't ever have to have, 0 twitches. If they have 1 or 2 twitches, they're totally fine. Now, if they've got 3 or 4, you probably want to put them down and give them a little bit more paralytic and to where they have it just half their twitches if you're using train of 4 to monitor. Only reverse when all 4 of the responses are present to the train of 4. And when you want to see if you can extubate your patient, you want to check for neuromuscular recovery prior to extubation post-reversal. And the best way to check is to make sure they have a sustained head lift for 5 seconds, a sustained leg lift for 5 seconds, sustained hand grip for 5 seconds, and sustained tongue depressor test, and maximum inspiratory pressure. Now, the sustained tongue depressor test is going to be kind of hard because with this one, the patient is supposed to bite down on the tongue depressor and hold it while you're trying to jerk it away. But if they have an ET tube in and maybe like a little bit of a bite block that you've created, they can't bite down on the tongue depressor test. But they can't bite down on the tongue depressor and hold it in place. But if they can hold their head up for 5 seconds, lift their leg up in the air for 5 seconds, give you a good squeeze, a hand squeeze for 5 seconds, and they are making maximum inspiratory pressures, then it's safe to know that they're able to be extubated and there's no residual blockade that's left over. So you just want to be totally sure, because the worst thing to do is be called back to PACU because you have to reintubate your patient because they were too weak. All right. So neurological monitoring, first up is EEG. And so with the EEG, there's a summation of excitatory and inhibitory postsynaptic potentials in the cerebral cortex. Electrodes are placed so that surface anatomy relates to cortical regions, and it uses at least 16 channels of information. It identifies consciousness, unconsciousness, seizure activity, the stages of sleep and coma, and inadequate oxygen delivery to the brain, so it'll alert us to hypoxemia or ischemia. And the signal description, so we look at amplitude, frequency, and time. Amplitude is size or voltage of a recorded signal. Frequency is the number of times per second the signal oscillates or crosses the 0 voltage line. And time is the duration of the sampling of the signal. Now, of course, there is a technician that monitors EEGs. We don't. So peri-op uses, they're used to identify inadequate blood flow to the cerebral cortex. Guides anesthetic induced reduction of cerebral metabolism. It's used to predict neurologic outcome after a brain insult, and it gauges the depth of a hypnotic state in patients under general anesthesia. And so the EEG signals, we have beta is greater than 13 hertz, and they are awake, and that's the alert, attentive brain. Alpha, and that's at 8 to 13 hertz, and usually that's eyes closed, and that's where we see our anesthetic effects. We see alpha waves. So the theta and delta waves, the thetas are at 4 to 7 hertz, and the delta waves are at less than 4 hertz, and these are depressed or slower frequencies. So the activated or higher frequencies and larger amplitudes, we'll see that in the beta waves with the patients that are actively awake. So the process EEG, and that's more along the lines what we use, like getting in line with the biz. So we'll talk about that next. It contains artifact along with the desired EEG signal. So it's taking an EEG signal and compressing it to something that we can try and process and use. And so it uses less than 4 channels of information. So it's going from the standard 16 channels and compressing it to less than 4 channels. And so that's 2 channels per hemisphere. So that can cause a lot of artifacts and can distort the EEG signal that is normally pretty clear. Um, it's necessary to display the activity of both hemispheres, so it delineates unilaterally from bilateral changes. So essentially, so like if you wanted to see regional ischemia due to carotid clamping, that's your unilateral changes. And if you wanted to see EEG depression from an anesthetic drug bolus, well, that's your bilateral changes because you're giving a bolus, but you're not differentiating between the left or right hemisphere. You're depressing both hemispheres. There hadn't been an adequate amount of studies comparing EEG to process EEG, and EEG is the gold standard. So there's not been enough studies comparing essentially like an EEG to a BIS to say that a BIS is preferred over an EEG. So the BIS, or the bispectral index, it processes EEG signal to estimate anesthetic depth and uses a computer-generated algorithm / weighting system. And it is proposed as a method to prevent intraoperative awareness. Now, this hasn't demonstrated to be superior to end-tidal agent concentration monitoring, specifically like for your gases, like like SIVO does or ISO. So traditionally, we just kind of monitor our end-tidal concentrations, and if we know that we're at a MAC or close to a MAC or a little bit over a MAC, we can generally predict that our patients won't have any intraoperative awareness. However, it's a prediction. It's not 100%, but in cases where there's intraoperative awareness, neither technique was found to be with complete reliability. So there's problems with both. And it's not saying there's some people that swear by a BIS, and there are some people that, think that it's like witchcraft, for instance. I've seen a BIS that would read, burst suppression like around 20, and it's just hanging in the air. It wasn't attached to a patient. So, there's problems with everything. So, like I said, and the problem with the BIS, it's going from 16 channels to 4 channels, or to less than 4 channels, and so it's processing a lot and trying to compress it. So that's a potential problem. This is a guide on the BIS because there's not much in our books about it. So if you do want to read up on that, click on this link. But you don't have to. But just know this information that's on the PowerPoint regarding the BIS. Okay, so sensory evoked responses. These are the most common type of evoked potentials that are monitored intraoperatively. They are electric CNS responses to electric, auditory, or visual stimuli, sensory system stimulus with responses that are recorded at various stages along the sensory pathway to the cerebral cortex, and they can be cortical or subcortical. And so cortical, they arise from the brain, and subcortical responses may arise from like peripheral nerves, spinal cord, brain stem, thalamus, cranial nerves, and various other places. But and these are also described in terms of latency and amplitude. Latency is the time measured from the application of the stimulus to the onset or peak of the response. Amplitude is the size or voltage of the recorded signal. And with this, we need a baseline that is reproducible with reliable tracing. So we always need, when the technician is in there, they're going to do a baseline either when the patient is awake to kind of have a baseline to see exactly where they're standing and where they're starting from. And these include somatosensory evoked potentials, SSEPs, brainstem auditory evoked potentials, BAEPs, and visual evoked potentials, VEPs. The most common ones that you're probably going to see are the somatosensory evoked potentials. Okay, so the somatosensory evoked potentials, or SSEPs, they monitor the responses to stimulation of peripheral mixed nerves and this contains motor and sensory nerves to the sensory and motor cortex. The responses consist of short latency and long latency waveforms. The short latency SSEPs are most commonly recorded intra-op and are less influenced by changes in anesthetic drug levels. Induction, neurological disease, or age, and the use of different recording electric locations can actually alter the appearance of SSEPs. And again, we don't monitor these. Technicians come in the OR and they monitor them for us. But they're great because whenever they are monitoring SSEPs or MEPs, the motor evoked potentials, they can tell you like, hey, I'm not conducting, I'm not getting through. And so, if like your patient's arm is being pitched in between an arm board or something, they can show that because they can tell like the nerve ending is being pinched, and so they're not conducting and getting through. So it's always good to know. So brainstem auditory evoked potentials and visual evoked potentials. So the BAPs, they monitor responses to click stimuli that are delivered via foam ear inserts along the auditory pathway from the ear to the auditory cortex. And then VEPs, they monitor responses to flash stimuli of the retina using light-emitting diodes embedded in soft plastic goggles through closed eyelids or contact lenses. These are least commonly used. So VEPs are the least commonly used monitoring technique intraoperatively, because usually the patient has to be like awake. They have to be awake. They have to be lucid and close their eyes, but they have to be awake. They have to be able to follow command with these. All right, so motor evoked potentials, and you'll see these along with SSEPs. These monitor the integrity of the motor tracts along the spinal column, the peripheral nerves, and innervated muscles. Innervated muscle. They're mostly they're transcranial motor evoked potentials, and these are the most common. These monitor stimuli along the motor tract via transcranial electrical stimulation overloading the motor cortex in the brain. Now, electromyography monitors the responses generated by cranial and peripheral motor nerves to allow early detection of surgically induced nerve damage and assessment of the level of nerve function intra-op. So a lot of times, if a tumor dissection is going on and there's a lot of nerves or muscle fibers that are being involved, a doc will take a probe, or the surgeon will take a probe and kind of stimulate the nerve where they're resecting the tumor, and see what kind of damage has been done there, and see if there's any way to try and save that nerve or and prevent further damage, and see if it's causing stimulus to that muscle like it's supposed to, or to that area that it's supposed to stimulate, that it's causing the correct stimulus. So this assesses the integrity of cranial and peripheral nerves at risk during surgery. Okay, so we're into temperature monitoring. Okay, so temperature control. Our primary thermoregulatory control center is at the hypothalamus, and unmyelinated C fibers, they carry our warmth and heat, our feelings of warmth and heat, and alpha delta fibers carry our feelings of cold. Alpha delta fibers carry our feelings of cold sensations. And our thermoregulatory response is characterized by threshold, gain, and responses. So threshold is the temperature at which a response will occur. Gain is the intensity of that response. And our responses are typically to being hot, sweating, vasodilation, and cold, vasoconstriction, and shivering. So sweating is mediated by postganglionic cholinergic or nerves, or acetylcholine, and vasodilation is mediated by the cholinergic system, and it diverts blood to the periphery where heat can be dissipated by the environment more easily, and it can lower our core temperatures. And vasoconstriction and shivering are our primary responses to cold, as I said earlier, and they're mediated by alpha 1 and alpha 2 adrenergic responses. I'm sorry. Gosh, I'm tired. Receptors. Now, the vasoconstriction reduces the amount of blood that's vulnerable to heat loss from the skin surface through, and we'll talk about how this happens through like different types, like convection and radiation, in a few slides down as well. So now temperature control can vary, like temperatures can vary by type of anesthesia, so like epidurals and spinals, or general age, menstrual cycle, drugs, alcohol, and circadian rhythms can all affect our temperatures. So hypothermia in general anesthesia. So there is an initial period where we have a rapid decrease of approximately 0.5 to 1.5 degrees Celsius. And this is anesthesia-induced vasodilation. We have increases in heat loss, and that's due to the redistribution of body heat. And this usually occurs over 30 minutes. And then so we hear we're vasoconstricted, anesthesia hits, and then we get vasodilated, and we're trying to redistribute our body heat. And then we have a slow linear reduction, which is a reduction of approximately 0.3 degrees Celsius per hour. And so general anesthesia decreases our metabolic rate by 20 to 30%, so that's a significant decrease. And our heat loss then exceeds production. So we're losing more heat than we're producing. And this happens usually about 1 to 2 hours after anesthesia has occurred. And then we enter a plateau phase. So this is the slow linear reduction, and this is the initial drop. And so when we hit that plateau phase, there's a thermal steady state that we hit, and the heat loss then equals heat production. So we're at just kind of like this homeostasis. We entered the steady state, and this occurs usually after about 3 to 4 hours of anesthesia. Now, vasoconstriction prevents loss of heat from the core, but peripheral heat continues to be lost. So this right here, our core, we're preventing loss here, but here in the periphery, so hands, legs, head, we're prone to losing heat. So that's when our adjuncts to keep our patients warm come into play. Now, hypothermia and neuroaxial anesthesia. Hypothermia does not cause much thermal discomfort, so patients don't complain of feeling cold or being cold. The central thermoregulatory control is inhibited by neuroaxial anesthesia, so that's why they don't complain as much. And so that decreases the thresholds that trigger the peripheral vasoconstriction and the shivering. So that's why you just don't see patients like with epidurals or spinals. They're not necessarily like complaining that they're cold because their thermoregulatory control has been inhibited. Autonomic thermoregulatory defenses are impaired as well, so vasodilation, the sweating, the vasoconstriction and shivering. So the responses to heat and the responses to cold, they're impaired. So we will see vasodilation, but that's just due to the drugs that are given in neuroaxial anesthesia, like in an epidural or in a spinal. Because from the dermatome level down, they are going to have that vasodilation or they're going to have vasodilation just about everywhere actually, but they're going to have vasodilation simply because of the drugs that are given neuraxially. So they aren't going to have, they're not being vasodilated in response to heat, like feeling hot, and they won't have that sweating, and they won't be vasoconstricted in response to cold. So let's see, there's an initial decrease in core temperature that's caused by neuroaxial blockade, induced vasodilation, which is what I was kind of talking about just a few seconds ago. And the patients may not plateau due to the inhibition of the peripheral vasoconstriction. So how we talked about that the patients ended up having that peripheral vasoconstriction with in general anesthesia, the patients with neuraxial anesthesia, they're not going to have that same peripheral vasoconstriction. So they're probably not going to reach the plateau phase. And the vasoconstriction threshold is centrally altered. So um, since that vasoconstriction threshold is centrally altered, they will probably just continue to drop. They will continue dropping at the linear rate and not hit that plateau phase. So we have to make sure that we are keeping them warm and we are keeping them cold. I'm sorry, that we are keeping them cold. Keeping them warm. Pause. I'm going to redo all that all over again. Okay, so hypothermia and neuroaxial anesthesia. Hypothermia does not cause much thermal discomfort, so the patients don't complain of feeling cold per se. Our central thermoregulatory control is inhibited by neuroaxial anesthesia. So this decreases the threshold that triggers the peripheral vasoconstriction and shivering. So with that, our autonomic thermoregulatory defenses are impaired. So our responses to heat and cold, they're totally impaired. So the patients don't have that normal response. An initial decrease in core temperature is caused by neurooptic blockade-induced vasodilation. And these patients may not plateau due to inhibition of the peripheral vasoconstriction. So like we saw in hypothermia with general anesthesia, the patients initially, they eventually hit a plateau phase and they vasoconstrict in the periphery. But these patients with neuraxial anesthesia, they do not get that vasoconstriction. And that's because that vasoconstriction threshold is centrally altered. For patients with neuraxial anesthesia, we have to be vigilant in keeping them warm. So using adjuncts such as a bear hugger or blankets to keep them warm to make sure, because everything is altered because of the neuraxial anesthesia. All of the normal responses are altered, so we have to work harder to keep them warm. So methods of heat transfer. Radiation is heat loss to the environment, and this accounts for about 40% of heat loss in patients, and it's their body surface areas being exposed to the environment. And in infants, since they have a high body surface area compared to the body mass, so that ratio, the BSA to body mass ratio, since the BSA is higher, this makes them extremely vulnerable to heat loss via radiation. Convection is the loss of heat to the air immediately surrounding the body, which accounts for approximately 30% of heat loss in patients. Clothing, drapes, and even like blankets, like basic blankets, they decrease heat loss via convection. Now, rooms that have greater air, that have a laminar airflow or greater laminar airflow, convection is increased. Convection heat loss is increased in patients. Evaporation is latent heat of evaporation. Evaporation is latent heat evaporation of water from open body cavities and the respiratory tract, and this accounts for approximately 8 to 10%. Evaporation is the latent heat of vaporization of water from open body cavities and the respiratory tract, and this accounts for approximately 8 to 10% of heat loss in patients. And so in the OR, usually this happens when like in abdominal, like open abdominal cases. So when the body cavity is open, or even an open chest, and it's been open to the environment for such a long time, you have some heat loss by evaporation. Now, in patients that are awake and walking and talking, that or people, not necessarily patients, but sweating is the main pathway of evaporation. Now, conduction is heat loss due to direct contact of body tissues or fluids with a colder material. And this is very minimal, very minimal heat loss in patients with this. So the examples of this would be like contact between the skin and the OR cable, or the intravascular compartment with an infusion of clove fluid. So, and generally they try to warm the fluid. So if they're going to wash out the belly and they like wash out with fluids, they usually take warm fluids, warm sterile fluids, and pour it into the body cavity, rinse, and then suction and remove. But if it's cold fluids, that's going to decrease the body's temperature. But normally, like I said, it's usually warm temperatures, and this really accounts for a very minimal amount of heat loss in patients. Okay, so hypothermia complications. Coagulopathy, so this impairs platelet aggregation and activity of enzymes involved in the coagulation cascade. And hypothermia also increases the need for transfusion by 22% in patients, and increases blood loss by 16%. It decreases oxygen delivery to the tissue, so it increases the risk of wound infection and decreases tissue healing. It increases the incidence by 3 times of morbid cardiac outcomes, so that we have increased blood pressure, heart rate, and plasma catecholamine levels, unfortunately. And shivering, and that increases oxygen demand. And with shivering, you can give some meperidine or Demerol, clonidine, or dexmedetomidine, even ketamine. That can reduce shivering and the vasoconstriction threshold in patients that are hypothermic or cold. Also decreases drug metabolism, so your patient may stay a little bit paralyzed longer with some neuromuscular blockers on board. So try and keep your patients warm so they can metabolize the drugs faster. Let's see what else. And it's post-op thermal discomfort, because when people are cold, they complain, and they are uncomfortable, and some of them can be shivering so violently that it's painful. So we have to make sure and if they do complain of any discomfort, we need to treat them, and it should be treated like postoperative pain and nausea. So we would need to actively try and warm them as well, and to reduce the pain and make them more comfortable, because we would not dismiss their postoperative pain or nausea. We would treat it accordingly. So if they have thermal discomfort that's postoperative, we need to treat it, and we would treat it by trying to, if they're shivering intensively, give some of the medications like the meperidine or the Demerol, clonidine, dexmedetomidine, ketamine if necessary, to reduce their shivering, and actively warm them to make them as comfortable as possible. Okay. So the benefits of hypothermia. So we've seen some hypothermia protocols in the hospital that we, induce hypothermia in patients that have been found down, after loss of consciousness, to try and protect against cerebral ischemia, and also even in CABG patients or heart patients, we induce some hypothermia to preserve tissues as well. So, hypothermia is protective against cerebral ischemia, and it reduces metabolism up to 8% per degree Celsius. It's also an improved outcome during recovery from cardiac arrest, as we talked about earlier, and neurosurgery when brain tissue ischemia is expected. And when patients are hypothermic, it's more difficult to trigger MH. All right. So how do we manage these patients? So airway heating and humidification, we normally do that, and it works better in infants and children over adults. But I mean, we can warm, we can use humidifiers and warm our gases and airs as and oxygen as it's going in through breathing circuits. But it really works better in infants and children. Excuse me. Excuse me. Warm IV fluids and blood, those prevents cooling, and we typically try and give them warm, especially if it's got to transfuse a lot, because if you're transfusing quite a bit, that can drop your temperature in the patient quite rapidly, actually. And then cutaneous warming, you can increase the room temperature. So in patients that are having liver transplants or major trauma or pediatrics, definitely pediatrics, you increase the room temperature. Insulation, so you can give a single blanket, and a single blanket reduces heat loss by 30%. However, insulation doesn't increase body temperature, so it's just going to reduce the heat loss. Hot water mattresses, they're more effective and safer if they're placed on top of the patients. A lot of people will try and put them underneath the patient, but it's more effective if they're on top of the patient, if the procedure allows them to be on top of the patient. Like if you're just working on an arm or an elbow or maybe like an ankle or something, and the patient is susceptible to a lot of heat loss, then if you have the capability of getting a hot water mattress, and you can put it on top, but don't recommend putting it under the patient because the patient could be susceptible to burns if it gets too hot. And generally it doesn't get that hot, but you just want to be safer than sorry. And then forced air warming, which is most common, so a bear hugger, and it's what you see right over here. And it prevents heat loss from radiation, and it also uses convection to transfer the heat that's being blown in. It uses convection to transfer heat to the patient. Monitoring sites. So your choice of monitoring site is going to depend on the surgical procedure, type of anesthesia, and the need for temperature monitoring. And so your best site, your golden site, is going to be the pulmonary artery, and it correlates well with the tympanic membrane, the distal esophageal, and nasopharyngeal temperatures. So if you had probes in these areas or were taking temperatures in these particular areas, your pulmonary artery will correlate well with those particular temperatures. However, we don't always monitor pulmonary artery except in major surgeries where a PA catheter is being placed. So like cabbages or valve surgeries of that nature. So the tympanic membrane, and that approximates temperature at the hypothalamus. However, if you are monitoring at this site, placement risks perforation. So if you're trying to put like a temperature probe at that particular site, you could risk rupturing there, or rupturing or perforation. Nasopharyngeal, so this also reflects brain temperature, but it's more prone to air because of displacement and possible secretions, and there's a risk of a nosebleed or epistaxis. So you want to avoid nasopharyngeal probes if possible. Esophageal probes, they are safe, they're easily accessible, they're artifact resistant, and it's an accurate site. The placement of the distal it's placed in the distal esophagus to the lower 1/3 to 1/4 of the esophagus. Now, the sites that are not the best, oral, axillary, rectal, bladder, and skin may not be the best sites. However, we use skin a lot because there are these skin temperature probes that you can place on the forehead that look like stickers. And although they're not very accurate, we use them sometimes in maybe surgeries that won't last as long, or shorter surgeries, or maybe if you're doing just like conscious sedation and your patient is just kind of going to be in and out of consciousness, and it's going to be a little bit longer, maybe last maybe an hour and a half, but they're going to be breathing. You're not going to be intubating them. You just want to maintain their temperature and make sure they're warm. You could put one of those on as well. Okay, so the OR temperature, last slide. It's usually at 70 degrees Fahrenheit or 21 degrees Celsius, and that's usually if it's warmed up for children or for, major trauma or liver transplant in those particular procedures or surgeries where you need to keep somebody warmer. And but typically it's at 65 degrees Fahrenheit or 18 degrees Celsius, so it's chilly in there. It is chilly in there. Please let me know if you have any questions or concerns, and we will talk next Thursday.